Welcome back from lunch, folks. I hope everybody got what they needed to nourish yourselves for the next part of this day today. We are going to start off after lunch here with our first afternoon presentation, item number 10, presentation on food security for children in Nevada. We have Sarah Rogers with the Office of Food Security with us on Zoom. Please introduce yourself and go ahead when you are ready.
Hi, Sarah Rogers. Let me share my screen really fast. Can you see my screen?
We can.
Okay. My name is Sarah Rogers. I'm the Nutrition Unit Deputy Chief with the Nevada Division of Public and Behavioral Health. And I'm here to talk a little bit about food security for children in Nevada. Food security means the ability of a person to access enough food for an active and healthy lifestyle. The Office of Food Security's mission is to effectively improve the quality of life and health of Nevadans by increasing food security throughout the state. The guiding principles of the Office of Food Security include incorporate economic development opportunities into food security solutions, use a comprehensive, coordinated approach to ending hunger and promoting health and nutrition, rather than just providing emergency short-term assistance. Focus on strategic partnerships among all levels of government, communities, nonprofit organizations, including foundations, private industries, universities, and research institutions. Use available resources in a more effective and efficient way. Implement research-based strategies to achieve measurable results. The target population for the office is food insecure Nevadans with an emphasis on children and older Nevadans. In addition, the Office of Food Security staffs the Nevada Governor's Council on Food Security and supports the implementation of its guiding plan, Food Security in Nevada, Nevada's Plan for Action. I'm going to briefly touch on the Governor's Council on Food Security. The council is hoping to provide a more in-depth presentation to this committee at a later date and would love to discuss all of its work that's been doing as a council and some of their COVID lessons. Our Governor's Council on Food Security was established by executive order in 2014. They meet 4 times per year. They're tasked with identifying priorities in food security, tasked with implementing the food security in Nevada plans for action, and they have 21 cross-sector members. Household food insecurity, state and national trends. Food insecurity rates have decreased from the high in 2013, which was 16.2%, to 12.9% in 2018. This was coming off of the Great Recession. And as we can see from this chart, there was a low of food insecurity in 2016 at 12.1%, which is the only time Nevada had a food insecurity rate lower than the national average in this time. U.S. childhood food insecurity trends. So from 2019 to 2020, food insecurity rates in households with children increased across all 3 measures. The measures being food insecurity in households with children, food insecurity among children, and very low food insecurity among children. Some food insecurity household characteristics. Overall, households with children had a substantially higher rate of food insecurity at 14.8% than those without children, which is 8.8%. Among households with children, married couple families had the lowest rate of food insecurity at 9.5%. And this is from 2020. This is Feeding America data in all 50 states. In all 50 states and Washington, D.C., the estimated rate of child food insecurity is higher than the rate of overall food insecurity. Child food insecurity rates range from 10% in North Dakota to 25% in Louisiana, with the national average being 17%. As we can see from this chart, Nevada is at 19.5% for food insecure children. The Supplemental Nutrition Assistance Program and the Pandemic Electronic Benefit Transfer, or PEBT, participation. So in April 2020, overall, there was an increase in SNAP applications across all ages, demographics, and Nevada counties between February and May 2020. As of April 2020, there were 201,985 children ranging from 0 to 18 on SNAP benefits. And that number has decreased. And as of April 2022, 185,432 children are currently enrolled in SNAP from ages 0 to 18. The majority of those children are in the age range between 6 and 12. That's 73,099. And then the pandemic EBT, or PEBT, was developed as a response to the pandemic and is for children ages 4 to 22 in grades pre-K to 12. In 2021 to 2022 school year, more than $96 million in PEBT benefits were issued to approximately 330,000 Nevada children, which is less than 2020 to 2021 school year, where approximately 340 million in PEBT benefits were issued to approximately 396,000 Nevada children. Summer PEBT was also issued. 151.7 million PEBT benefits were issued to approximately 396,000 children since 2020. Summer PEBT is approximately $375 per eligible child. Women, infants, and children participation. Between March and April 2020, the greatest increase among what WIC participation type was seen. This was among pregnant women and children participants. During the height of the pandemic, WIC saw an increase in participation, but an overall decrease in actual food redemption. September 2021 is when participation fell below pre-pandemic levels, which there are various barriers for WIC participation that we do attribute to this decrease. There were improvements made in SNAP shopping, but not improvements made in WIC shopping, such as online shopping capabilities. WIC appointment requirements and clinics started to open back up, requiring them to come back in person. WIC does require more follow-up to maintain benefits. Also, WIC benefits are not monetary, they are prescription style benefits. So you get a specific benefit package. You don't get to choose what you purchase with your WIC benefits. Less than half of the women and children who are eligible to participate in WIC actually participate. All of the children in the 0 to 5 range who are participating in SNAP are objectively eligible to participate in WIC. And as you can see from the chart on the previous slide, that was around 60,000 children 0 to 5 are participating in SNAP. And as of April 2022, 40,489 0 to 5 year olds are participating in WIC. So there is a disparity there. The Nevada food insecurity. In Nevada, 388,420 people are struggling with hunger, of which 134,350 are children. 1 in 8 Nevadans are food insecure, and 1 in 5 Nevada children are food insecure. The COVID-19 pandemic has led to an unprecedented increase in food security and need for nutrition services statewide and nationally. According to Feeding America, Nevada is projected to rank 8th nationally regarding rates of projected food insecurity in 2020 versus 2018. 6 Nevada counties experienced more than a 30% increase in food insecurity from 2018 to 2020. Those counties being Douglas, Elko, Lyon, Story, Washoe, and Clark County. Clark County experienced the largest increase of food insecurity from 12.8% to 20.1% in 2020. And the implications of child food insecurity. There's a large, broad base of literature illustrating links between food insecurity and poor child health and behavioral outcomes at every age. Some are birth complications, so low birth weights. Low birth weights among infants is more common in counties with higher food insecurity rates. There are poor maternal outcomes and iron deficiencies. There are also developmental implications such as stunted growth, anemia, asthma, oral health problems, mental health disorders, and lower cognitive level. And then some other just overall negative health outcomes, lower quality diets or nutrition insecurity, higher healthcare costs, higher obesity rates. And overall food security is just linked to poor quality of life, which may prevent children from fully engaging in day-to-day activities. So some lessons learned from COVID-19. Amid the COVID-19 pandemic, statewide food security partners faced unprecedented new challenges as the pandemic implications reversed Nevada's improvements in addressing food insecurity. The economic shutdown led to a staggering increase in unemployment, resulting in increased need for nutrition services. There were also widespread physical school closing, which meant millions of children had lost their access to subsidized school meals. These meals often play a key role in helping families meet their children's basic food and nutrition needs. The lessons we learned from the COVID-19 pandemic was there was a disproportionate impact on racial and ethnic minorities, senior citizens, households with children, and people with chronic diseases. Programs had to pivot very quickly and enhance programming to adjust to increased needs and social distancing guidelines, resulting in innovative programs and collaborations, such as drive-through distributions and RTC home delivery programs, among other delivery programs. Overall, there was an increase in program utilization between March and May 2020, such as food bank donation distributions, SNAP, and then Department of Agriculture programming. SNAP and WIC waivers were required to continue to serve and need participants throughout the pandemic. There was identified technology advancements that WIC needs to continue to work on to serve their population. The supply chain issues increased the need to expand the food options for WIC, and we need to establish better connections with the Nevada Department of Transportation, collaborate better on food security needs for the state. In current efforts of food security, we are currently in the process of conducting our food security strategic plan. So far, we have conducted more than 1,000 community member surveys and 67 food security provider surveys. We are in the process right now of conducting focus groups with state community partners, community members. The strategic plan will advise the Office on Food Security on policy recommendations for state food security efforts. We have our first strategic planning meeting, which is held in person. That will be taking place in Carson City on May 24th, and it is open to all food security stakeholders. We have also the chronic disease section in partnership with the Office of Food Security has applied for and received the State Partnerships Improving Nutrition Equity Grant through the National Association of Chronic Disease Directors. And this will help us work more on nutrition and equity across the food system as well. And then I am available to answer any questions.
Thank you so much, Mrs. Rogers. Are there any questions from the committee on this particular presentation? I can't see you in Zoom or Southern Nevada, so please let me know if you have a comment or question. All right, I do. Can you talk a little bit about what the biggest differences are between WIC and SNAP programs?
Yeah, so I'm more well-versed in WIC, as WIC is part of our nutrition unit, but WIC is a program that is open to pregnant women or pregnant parents, postpartum parents, breastfeeding parents up to a year breastfeeding or 6 months postpartum if they're not breastfeeding, and children 0 to 5 years old or up to their 5th birthday. The income eligibility for WIC is a little bit higher than SNAP, but the requirements to maintain benefits on WIC is a little bit more. It requires a little bit more. You have to do at least quarterly nutrition education. They do individual targeted nutrition ed, provide breastfeeding support, breast pumps to moms in need, and it's a prescription style food package. So on average, I believe the actual cost of a WIC food package comes out to about $35 per individual. Of course, it's a little bit higher it's a lot higher if we are providing formula on their package. And SNAP is monetary benefits, so they have more options and ability to purchase a wider variety of foods, where WIC foods are mainly eggs, low-fat dairy products, some cheeses, yogurt, cereal, hot cereal, cold cereal.
Okay, I was thinking about the slide where you talked a little bit about that there's a disparity in who accesses WIC versus who accesses SNAP. And I was wondering if we could kind of just see what the difference was in what was provided and maybe dive into what those disparities look like. How do people apply for WIC versus SNAP? Are they through the same application process, or are they separate programs?
No, they're separate. We do get WIC referrals through the Division of Welfare. So if someone's going to apply for SNAP and the Division of Welfare identifies that they could also qualify for WIC, we do have a relationship with SNAP where we do get those referrals, but the participant would have to call their closest local WIC agency and apply separately. And it's a certification appointment, so they are required to have a height and weight taken, depending on the type of participant. If it's a pregnant woman or child, we do require iron to be taken. So that can be a little poke on the finger or referral to a clinic to get their iron levels checked. Height and weight needs to be checked at least twice a year or once a year, twice, depending on if they're higher risk or not. And they are assigned risk nutrition risk codes to identify if they're a lower nutrition risk or a higher nutrition risk. And so they are required to go through the individual counseling and get some anthropometrics taken to get fully certified on the program.
Okay, thank you so much for that additional information. Are there any other questions from the committee? I'm not seeing any. Unmute yourself if you would, and I missed you. All right, well, thank you, Ms. Rogers, so much for the presentation. Appreciate your work. And we will go ahead and close that agenda item and move on to the next presentation, which is also you. So we're going to talk about in this next item the overview of childhood obesity in Nevada. So please, Ms. Rogers, go ahead.
Let me share my screen. I'm sorry, it keeps exiting me out. Okay, are you able to see this screen now?
We sure do, thank you.
Okay, so again, I'm Sarah Rogers. I'm the Nutrition Unit Deputy with the Division of Public and Behavioral Health, and I will now present a little bit on childhood obesity in Nevada. The Chronic Disease Prevention and Health Promotion Program's mission is to improve health outcomes and quality of life by promoting health and wellness to prevent chronic disease, and reduce the burden of disease for those already living with chronic conditions. In 2017, the Nevada Legislature defined the term obesity as a chronic disease characterized by an abnormal and unhealthy accumulation of body fat, which is statistically correlated with premature mortality, hypertension, heart disease, diabetes, cancer, and other conditions. The clinical diagnosis of childhood obesity is falling at or above the 95th percentile, which is based off of a calculation of the individual's height and weight. National obesity prevalence. From 2017 to 2018, 19.3% of children were considered obese. Obesity rates for children and adults has been at a steady increase. Childhood obesity rates are lower than those of adults, but as we can see from this graph, they follow similar trends in chronic disease in Nevada. Obesity is the most prevalent chronic disease in Nevada at 28.7%. However, it is lower than the national average, which is 31.9%. And youth obesity in Nevada. The percentage of youth whose BMI qualifies them as obese continues to increase over the long term. In 2019, youth obesity increased from 11.4% in 2013 to 12.3% in 2019, compared to the percentage of the national youth obesity in 2019, which falls at 15.5%. Nevada youth obesity trends show a significant gender disparity. The percent difference of obese male students is significantly higher than females, with 7.5% of females to 15.3% of males classified as obese in 2013, and 9.3% of females to 15% of males classified as obese in 2019. So obesity among kindergarteners, according to the Nevada Kindergarten Health Survey, over the years, the percentage of kindergarteners whose BMI qualifies them as obese has decreased from 21.4% in 2015 to 18.7% in 2020. The percentage of children classified as overweight has increased over time from 10.6% in 2015 to 13.2% in 2020. And obesity prevalence among 2 to 4 year olds. Nevada childhood obesity trends among children aged 2 to 4 years who are enrolled in the special supplemental nutrition program for women, infants, and children show a statistically significant decline in 2018, which is 11.7% of WIC participants had obesity, which is a decline from 13.8% in 2008. Nevada childhood obesity trends by sex among WIC participants show statistically significant disparities again. The percentage difference of obese WIC participant boys 2 to 4 years old is higher than the percentage of obese girls, from 12.9% of girls to 14.6% of boys classified as obese in 2008, and then 10.8% of girls to 12.6% of boys classified as obese in 2018. In 2018, the highest percentage of unhealthy weight status was among American Indian Alaska Native children, which was 18.1% were overweight, 15.2% high weight for length, and 12.2% were obese. The second highest was among Hispanic children, which was 16.1% were overweight, 14.5% were obese, and 12.5% had a high weight for length. So just some summary. The highest rate of youth and childhood obesity by gender is among Nevada boys. Youth obesity increased from 11.4% to 12.3% from 2013 to 2019. Nevada WIC childhood obesity decreased from 13.8% in 2008 to 11.7% in 2018. In Nevada WIC, American Indian, Alaska Native, and Hispanic children had the highest rates of obesity compared to races and ethnicities. So some challenges. One would be funding for a state prevention and wellness program. It is currently unstable and limited. Also, the school height and weight NRS collection, the reporting tends to be inconsistent. There is not standardized, and they have a lack of equipment to do so. Height and weight is being collected with various types of equipment and utilizing various methods. Not all the schools have height and weight collection equipment. And then COVID-19 implications would be time and ability for nurses. Nurses were reassigned to COVID-specific tasks. They are currently understaffed, and they don't have the ability to collect all the height and weight data that they need to. There's also absences and school closures that reduce the ability to collect this information since the start of the pandemic. So self-reported height and weight in the kindergarten health survey, the behavioral risk factor surveillance system, and the youth risk behavioral surveillance system. Evidence shows that self-reported or perceived BMI is significantly lower than when an individual's BMI is actually measured. Then the obesity status of 0 to 4-year-olds. The WIC data is most used and the most reliable. Nevada WIC serves approximately 12,000 1 to 5-year-olds, which is a small percentage of Nevada's entire 1 to 5-year-old population. WIC also provides individualized nutrition education and supplemental nutritious foods, which has shown to improve the BMI status of children participating in WIC versus those not participating in WIC. So it's not a good measure to compare or represent the state as a whole. And body mass index measure by itself should not be used to guide prevention and management efforts. BMI is only a perceived risk, and many other measurements, environmental and genetic factors may need to be taken into account to fully address the obesity problem. And then some successes. Our chronic disease prevention and health promotion program is currently in the process of updating the strategic plan. They're on a similar path as I mentioned for our food security strategic plan. They're a little bit behind in the process. They started a little bit later, but so far we've gotten some great responses and feedback. Again, this strategic plan will help to update the chronic disease priorities and identify efforts across the state. Some potential opportunities for childhood obesity would be to increase the availability of measured data, standardize and fund school height and weight data collection efforts, provide culturally appropriate, inclusive, and destigmatized weight education, encourage participation in federal nutrition programs, and provide mandatory or have mandatory physical education and physical activity in schools. More priorities could be to develop a robust surveillance system and wellness program. The cost for this would be estimated around $4 million a year, just based on similar models in other states. The current disease-specific funds are restrictive and cannot be utilized for comprehensive surveillance or development of a robust wellness program to address mental health, oral health, nutrition, and physical activity. These dollars could support the wellness manager, a wellness coordinator, a wellness evaluator, which would be needed to oversee program implementation efforts, support the growth of a 5210, a healthy children's program, utilize peer community health worker models in schools for youth wellness, and increase dedicated personnel for an oral health program, supporting comprehensive programs that address risk factors and meet the needs of Nevadans. Evidence would indicate that these increased funding and resulting capacity and resources would improve health outcomes related to chronic disease, as well as improve overall wellness and quality of life for Nevadan children. And again, any questions?
Thank you for the presentation. Are there any questions from the committee on this particular information? I am not seeing Grant Sawyer or our virtual folks, so if you have a question, please go ahead and unmute yourself and let me know. I don't see anybody coming up for questions, so thank you so much for the data. I do want to just point out that I appreciate the on your challenges slide, pointing out that the BMI measure by itself should not be used to guide prevention and management efforts. And I would be interested in what kind of solutions or proposals or programs you have in place to ensure that that's not the case, and that we're moving forward with really holistic models of prevention and management for folks, because everybody is different. So that's not necessarily something you have to answer today if you don't have that in front of you, but in the future we'd like to hear from you on that piece.
Yeah, no, it's absolutely something we're thinking about.
Fantastic. Anything we can do to help, let us know, please. Okay. Well, thank you again so much for your presentations today, Ms. Rogers. We appreciate you being here. We'll go ahead and move on to our next agenda item. Our agenda item 12 is access to childcare, successes and challenges. We have Carissa Machado. I am sorry if I said that incorrectly. Okay, with the agency. She's the agency manager for childcare and development programs. Please introduce yourself and proceed when you're ready.
Thank you, Chair. I will share my screen. Okay, can you see the presentation?
We can, thank you.
Awesome, wonderful. Good afternoon, committee members. My name is Carissa Loper Machado. I am the agency manager for the Child Care and Development Program for the Nevada Division of Welfare and Supportive Services. Thank you for inviting me to present today to discuss Nevada's efforts to address the challenges in our child care system, the federal relief funds. Oh, I'm sorry, I'm trying to move my slide. There we go. The federal relief funds and further investments from Governor Sisolak are allowing Nevada to make system changes and investments intended to create long-term improvements, as well as immediate stabilization of the industry. Nevada's Child Care and Development Program is housed in the Division of Welfare and Supportive Services of the Department of Health and Human Services. We are the lead agency administering the Child Care and Development Block Grant and associated Child Care and Development Fund, which funds child care subsidies for Nevadans, as well as other programming. We provide high quality programming to ensure a safe, stable, and healthy start for all Nevada children. We collaborate with diverse stakeholders, including the Division of Public and Behavioral Health for Child Care Licensing, the Nevada Department of Education, and their Office of Early Learning and Development, a multitude of community partners, and local municipalities to foster successful and healthy communities. Finally, we use data to identify and invest in child care expansion and improvement opportunities, which support families and Nevada's economy. The future of our child care system depends on better integration and alignment among all key stakeholders. In particular, we need to address 4 concurrent challenges: affordability for parents and caregivers, the capacity of licensed and other child care provider types, accessibility of child care to all Nevadans, particularly families living in child care deserts, including the fostering of a diverse set of provider options, and improving the quality of early childhood education and care delivery in close partnership with NDE's Office of Early Learning and Development. The changes we have made to date include efforts to support Nevada's families as well as our child care provider network. First, we have increased the income eligibility for a household to qualify for a child care subsidy from 130% of the federal poverty level to now 85% of the state's median income. This essentially has doubled the amount a household can earn monthly and be eligible for a child care subsidy, something like $1,500 a month for a household of 4 to $3,000 a month, as for an example. This change increases access to the subsidy program and affordability for more Nevada families. Another key policy change that improves access and affordability is the allowance of education and training without associated work as an accepted purpose of care for participation in the child care subsidy program. So restrictive implementation of older policies, which were implemented when our budgets were much, much smaller, even before normal federal increases in the block grant award, may be preventing Nevadans from being able to finish their education or attend a vocational training program if they also need access to childcare. The federal block grant rules allow us to define and include education and training as a purpose of care, And we have now, as of this month, expanded that ability back. We used to, in 2011, allow this. So now we're allowing it again to allow more Nevadans to achieve economic success. The final subsidy program policy change intended to improve access and affordability for families is to expand the amount of subsidy coverage to targeted subpopulations, which must be approved by the Federal Administration of Children and Families, which awards the block grant. We've been successful in receiving approval to add 2 additional targeted populations for whom we can cover 100% subsidy with no required copay. In Nevada, the subsidy program is administered on a sliding scale fee, as in many other states. Families are required to pay a copay based on their household income, and which is a federal requirement of subsidy participation as well, unless you have these approved subpopulations. In Nevada, the currently approved subpopulations are listed there on the slide, including our new employees of Nevada families that participate in the Temporary Assistance for Needy Families program, children involved with child protective services or in the foster care system, and children who are experiencing homelessness. In Nevada, we know some populations are disproportionately impacted by the cost of childcare to the point it can prevent them from achieving economic success. And we know considerations need to be made to allow stability for children in other special circumstances. The populations we are adding are listed here, including public and civil servants essential to Nevada's economic recovery. So that would include school district employees and staff, for example, state of Nevada employees, other county employees who already meet the income eligibility level. We can now help them with a 100% subsidy coverage. We are also have added individuals attending a substance use disorder treatment or recovery program through the Nevada Division of Public and Behavioral Health, and are actively meeting and partnering with our behavioral health partners and the substance abuse prevention and treatment partners and their care providers to assist individuals in those treatment programs to receive child care when they need that to do so. We also know that expanding access is not effective if we are not also lifting up Nevada's child care providers and the child care workforce. To that end, this month we have notified licensed providers that the subsidy program has raised the rates it will pay providers to the 95th percentile of the 2018 market rate survey. Based on the ages of children served and a licensed provider's quality rating through the Quality Rating and Improvement System, or QIRS, providers are seeing increases of $5 to $15 per day per child in their subsidy rates from what they were prior to this month. For example, rates for seeing an infant have increased anywhere from $4 to about $7 per day based on the quality rating cycle. And that is different for each child in an infant setting or a toddler setting, a pre-kindergarten setting, or a school-age child. So you can see there's a large range of providers and how their rates are calculated. We are also in the process, I do apologize, I moved that too soon. We are in the process of conducting the 2022 market rate survey. You may have just heard us say it's the 2018 market rate survey. That's the last one we have. We are working with Children's Cabinet actively to conduct the 2022 market rate survey, and we'll have a much better look at today's costs of providing childcare for our childcare providers across the state of Nevada very soon, by this summer, I expect by July. Now, we are doing a lot more with the American Rescue Plan Act award dollars and the investments that have already been provided to us. So I will try to go through these as quickly as I can, but I did ask Patrick for at least 15 minutes, knowing this would get comprehensive. There are the Child Care Stabilization Grants. This is over $200 million in direct stipends that have been provided to child care providers for up to 6 months, as budget would allow, for supporting their operations. They needed to use that to support both keeping on a workforce, supporting their staff with either bonuses or training and development coverage, or other staff supports, as well as supporting families. We have also been working to help not just centers or large providers, but individual staff through the Early Childhood Educator Staff Stipend Project, which is providing financial incentives to childcare providers who are active members of the Nevada Registry, which is currently required for all staff who work in a licensed environment. And they just need to be working in a qualified program at their time of application. That has so far received more than 4,000 applications, of which more than half have been completely vetted through the Nevada Association for the Education of Young Children, who is working with us to make sure staff are aware of this and are applying. And we've paid $1,000 staff stipends to over 800 staff so far, with more reimbursements in the works. We're also supporting what is now titled the Nevada Strong Start Child Care Services Center, was early on being dubbed a shared services hub for child care providers. So you may have heard that language as well. But basically what this is a provider resource center, a one-stop shop, if you will, for child care providers to access resources to help them run their business, improve their business, access shared services operations like HR support, payroll support, website development, etc. And we have a variety of partners and services listed here that are working with us. There are physical locations in Las Vegas that opened in February of 2022. You may have seen the grand opening for that. It was televised. We had Nevada's delegation and Governor Sisolak there, and it was a very exciting event. And we will be having a grand opening for the Reno location in late June, we expect. They are right now furnishing the building and everything. There is also a virtual center, and that virtual center is live and is bringing to Nevada providers more than 2,000 resources, guidebooks, toolkits, policy suggestions, documents they can use within their own business, etc., to assist child care providers in providing quality services and improving their services. The partners included here are Wonder School, which is a private entity working with us to provide website development, as well as assist providers in achieving all of the health, safety, and child development trainings that they need to be successful in providing child care. Ken Dellin, Kith and Ken, is an important partner that's allowing us to reach better into the Spanish-speaking community and our Hispanic community in Nevada by really developing the family, friend, and neighbor network and ensuring that though that network is not licensed, they are registered and can receive subsidy by becoming registered and payment, and receive the proper health and safety trainings that we expect in Nevada to allow children to be cared for in a safe environment. We have, of course, quality rating and improvement system, the Nevada Children's Cabinet, Las Vegas Urban League. We have the community health worker program, which is focusing on an early childhood education certification process. Those CHWs will be housed in both the North and the South to help providers and families navigate their various social determinants of health from the child care setting, and really provide that holistic, as Chair Peters mentioned, holistic type of service and care. Additionally, we have an early childhood substitute network, which helps our licensed providers get a substitute if they have a teacher call out for a day or two. So that's a great network that helps the whole state be connected to educators that are ready and willing to come and help. We have childcare startup and expansion grants that are available to family and home child-based care providers from $10,000 to $40,000, depending on the provider setting. That will allow them to improve the supplies they're using, including toys or other things that will help for the children or provider supports that are needed. There's now the capital expansion grant that the governor's office very graciously but allowed $30 million of the federal relief funding to come out, and the Interim Finance Committee approved for us. So that pre-application phase is live right now. Licensed childcare providers and other service providers in the early intervention space for children and youth with special health care needs are able to apply for an amount that has not been capped at this time. We're just taking in applications. So this $30 million, we expect to help a significant portion of childcare providers expand their capacity, renovate to expand capacity, et cetera. It is for construction costs only. And then the other support programs I've talked about are helping us round out the supports we can provide to the childcare system. We're working on infant toddler slot expansion. This is another way to help stabilize providers and allow them to expand the slots available for infant and toddler care, which we know there's a dearth of compared to pre-kindergarten and other care. We're working on background check fee assistance. This is sometimes a barrier to getting people into the workforce quickly, and we can work with our licensing partners and partners at the Department of Public Safety to ensure child care workers that we're going through that process as streamlined as possible, still accurately and comprehensively, but seeing where we can streamline that and help providers pay for their workforce to get those background checks done, because sometimes that is a barrier for that lower wage workforce. There's also business consultations, and that's also through the Shared Services Hub in helping providers access loans or other improvements, financial assistance that would help them expand capacity or improve their childcare business otherwise. There is a Child Care Provider Action Committee, which is bringing together all of these state and resource support partners, along with the provider community, those providing care in our licensed centers, et cetera, to come together and have discussions so we can hear directly what providers need from us to provide childcare services and expand childcare services. We also have a Nevada Youth First program. We're really working with a variety of businesses as well as other community partners to steer young adults into the childcare workforce. If they have not really decided what they want to do, we want to encourage people to enter the childcare and early education and development field so we can develop a robust workforce and a great pipeline, a career pipeline for people that they want to enter into, knowing that childcare is a huge need of impacting the economy overall, which will require childcare workers as well. So we also have family supports, along with the expanded subsidy eligibility and other things I already discussed that were subsidy program changes. We are partnering with the Children's Cabinet to operate an education outreach campaign that is meant to statewide ensure everyone is informed of all of these system and policy improvements we're making to impact the childcare system, to improve access, increase access, improve affordability, and lift up our provider system. We have parent leader engagement. So just like we're trying to ensure we're doing better at communicating with and hearing from our childcare providers, we want that from parents as well. And we're working with a variety of partners, including the Division of Child and Family Services and others on special needs consultation for infants and early childhood mental health to ensure families are supported there, and also that providers receive the trainings and support they need to help all children and provide care to all children. And that is my presentation, and I am here for all of your questions. Thank you so much.
Thank you so much for the presentation. Really exciting work being done in this space. I just want to remind the committee that this kind of information is maybe not typical of our committee. That because of the way this committee was formed, we have taken on child care and child welfare issues, and I wanted to expand on that because really child care is about family health and family stability, and that is our charge. So thank you so much for the presentation on where we stand and that great effort happening in your office. Are there any questions from the committee on this particular topic? I see Dr. Hardy, please go ahead.
Thank you, Madam Chair. So do they just, I'm talking about a family or a provider, do they just call you with the number that's on the bottom of your slide, and then your office tells them what their options are, where they can go and what they can do? Is there somewhere where they can find all these opportunities?
Yes, thank you, Dr. Hardy, Chair, through you. On the NevadaChildcare.org website, providers and parents can find assistance. It is not calling the state office. We do work with 2 child care resource and referral centers. So that is the Children's Cabinet serves Northern and Rural Nevada, and Las Vegas Urban League serves the Clark County and some of the rural Southern Nevada area. And I can ensure that the committee receives that information, but also if anyone were searching for subsidy assistance, no matter what website they end up on, they will be referred to the correct organization that helps them. NevadaChildcare.org, again, is the main website we like to send both providers and families to, because that can help them navigate appropriately.
When you just put your phone number, I thought you wanted all those calls. I'm smiling. Thank you.
Thank you, Dr. Hardy. That is a good point. Thank you for that URL. We can send folks there as they come up. Kind of along those lines, are providers able to suggest that their parents go through that channel, or caregivers go through those channels to determine eligibility, or is that really a burden on the parent and caregiver? And also, please feel free to go straight to members of the committee, and remember to introduce or to say your name for the record.
Thank you, Chair. Carissa Loper Machado, for the record. Yes, we work with the Children's Cabinet and Urban League. I'm sorry, I got caught up in forgetting my name and I forgot your question.
No, the question was, are providers encouraged to recommend that their parents go to that website?
Thank you. Yes, so providers that are members of the subsidy network already are well connected between Children's Cabinet or Urban League, and they know when they have, say, a new family come in and are helping them understand their rates and their budget. They know to be able to refer that parent over to one of the child care resource and referral centers for help applying for subsidy assistance.
Thank you so much. And through the Division of Welfare and Supportive Services, do you guys offer these the subsidies to clients who come in who are found eligible through other methods, or is this something they have to search for or ask for separately from your the division's initial process?
So there is a direct, Carissa Loper Machado, agency manager for the record. There is a direct referral link between our welfare and supportive services offices and those who do the temporary assistance for needy families or supplemental nutrition assistance program and Medicaid. They can, I believe through the access system, say they also need child care assistance. And there is a direct referral link that comes from our site at Welfare over to directly some folks at Urban League and Children's Cabinet. And I recently asked those partners how that referral process works for them. Do they believe it is successful for the clients? And they said yes.
Wonderful. Thank you so much. Are there any other questions from the committee? Please go ahead and unmute yourself if you have a question and I have not called on you. Not seeing anyone else. Thank you so much again for the presentation. Really appreciate your time today. We're going to go ahead and close that agenda item and move on to our next agenda item, which is we have a couple of folks presenting, so this is going to be a 2 presentation agenda item on an overview of early childhood development, adverse childhood experiences, and improving health outcomes for children in Nevada. First, we'll hear an overview of early childhood development and adverse childhood experiences from representatives of the Children's Cabinet, followed by ways to improve health outcomes for children in Nevada and policy considerations by representatives of the Children's Advocacy Alliance. Please, we have our, I think our Children's Cabinet representative here in Carson City. Please go ahead and introduce yourself and begin when you're ready.
Thank you, Chair Peters, members of the committee. Really appreciate the invitation today. My name is Marty Elquist, and I am the Department Director for the Children's Cabinet Supporting Early Education and Development Department. And I pressed F5 and I don't, there it goes, just have to be patient. Okay, thank you so much. I'm here with my colleague Denise Tanata, who is joining in person in Las Vegas, and I'm going to go over some basics on early childhood development, focusing on the early learning brain science. And then Denise is going to talk about system improvements and a grant that we have with the Health Resources Services Agency, known as Hersa. So briefly, there's been a ton of research done in brain science, specifically with young children over the last 15 years. And what we know through imaging is that brains are built over time, and skills build on skills. And our brain architecture is comprised of billions of neurons, and connections between those neurons are what builds our brains and provide the foundation for us as human beings. The connections of both genes and experiences shape the developing brain. So you have what you bring in from nature and then what is nurtured. The cognitive, emotional, and social capabilities, they're interrelated and intertwined throughout our lifetimes. And we know that experiences are critical in the outcomes that we all have as humans. And we know that children that are in toxic stress environments, it actually weakens their brain architecture. And the developing brain, then we have, it can lead to lifelong problems in learning, behavior, physical, mental health, and we all end up paying the price fivefold later on in life. We know that positive early childhood experiences are critical in supporting our children's development, and how we support our parents in supporting children through the services we provide, it's essential. So quickly on the screen, we are all born with the neurons we're ever going to have. That what the brain growth, when we refer to brain growth, we're referring to the connections that are being made between these neurons. And those connections are called synapses. And they are stimulated by the type of early childhood experiences that children have and the interactions that children have. And this is true for both positive and negative experiences, and that's important to remember. Scientists estimate that our synapses, we make 1 million synapses from birth to age 3, 1 million every second. And so when you think about those experiences you have with young children, knowing that brain development happens through interactions and relationships, and you see the stress our parents are going through during that critical developmental period, it's essential that we all understand this, and we really have to shift the culture and the thinking of how we raise our children and support our parents through this critical developmental time. And as the brain makes all these connections, that's what builds the brain, and that's what when we refer to brain growth, that's what we're referring to. So just quickly, synapses, here's the rapid period of growth. You lose it, you use it, or you lose it. And that's what's getting reinforced. So here's an image of a newborn, and then 1 month, 3 months. You see the rapid connection happening, 6 months, 1 year, 2 years. Look how dense that's getting, 4 years, 6 years. All of these passageways that you're seeing between these neurons, those are experiences formed over and over and over again, both positive and negative, important to remember. And then at about 6 years, what starts to happen is called pruning. And it's a natural process. And what happens is those connections then that are no longer being continually reinforced, those connections start pruning away. The child's brain says, I don't really use that anymore. It's not my experience anymore. It's, I'm not going to build those connections in my brain. Again, important to remember for both positive and negative experiences. Brain growth does not happen without relationships. Relationships are absolutely critical. We're born as social human beings. We're born with this desire to reach out and interact, connect with eye contact, to coo, to be responded to cry, to be fed a bottle, to change a diaper. Because we are social beings and these social cues are critical for communication in early childhood. Babies are absolutely born seeking that human connection and that response and understanding the communications of infants and toddlers is critical in how we respond and form those synapses, the positive ones, right? So children learn in and from relationships. Learning does not happen absent a relationship. And it's important that we all know, and we say this over and over again, that the first teachers of a child, mother, father, essential, or other caregiver. An infant must be in a nurturing and affectionate relationship with a caring adult in order for that positive development to occur in social realms, emotional, mental, physical, and then cognitive. And it's well-rounded. You don't just teach to cognitive or, ABCs without other social, emotional growth happening at the same time. You can't pick how we learn apart. It's all integrated. And through that learning, stress is normal. And positive stress response is normal. And this is characterized by, brief increases in heart rate, elevated hormone levels in things that like first day of school or getting an immunization. These are normal things where, we get a little elevated stress response, but there's a loving caregiver there to buffer the response. The time that stress period happens is generally short. So these are called positive stress responses. And then there are tolerable stress responses. These are, they're a little more prolonged, longer lasting difficulties such as the loss of a loved one, a natural disaster, or a really frightening injury like being bit by a dog, in early childhood. If the activation of that stress response is time limited and buffered by positive relationships, then the child adapts, the brain and other organs recover from that stress. So children experience a couple episodes of tolerable stress, but as long as they're buffered by loving, caring folks in the child's life, they're easily overcome. And then the third type is toxic stress response. And a toxic stress response occurs when a child experiences strong, frequent, and prolonged adversity, such as physical emotional abuse, chronic neglect, caregiver substance abuse, mental illness, exposure to violence, and accumulated burdens of family economic hardship. We heard a number of them today. food insecurities. And these experiences come without adequate adult support. So an adult to buffer those negative experiences with positive interactions. This type of toxic stress has long-term impacts on children's brain architecture and other development of our organs. And the increased risk for stress-related disease, such as cognitive impairment, well into adult years. Heart disease, diabetes. When we have multi-generations experiencing poverty and toxic stress, it changes our DNA. And the science is clear on that. So later health problems, I mentioned heart disease, diabetes, in substance abuse of the person experiencing the toxic stress themselves, and depression. But research also indicates that supportive, responsive relationships with caring adults as early in life as possible can prevent or reverse these damages. So just because somebody experiences toxic stress doesn't mean you can't recover from it. It's just going to take a lot to support that person to overcome all those connections that have been made in that brain. So these experiences are known as ACEs. They're called Adverse Childhood Experiences, and they can, I mentioned it already, emotional abuse, neglect, mental illness, household violence. But the more ACEs a child experiences, the more likely he or she is to suffer from things like heart disease. So 3+ adverse childhood experiences is in that toxic stress zone. And this information came just through my email today from the National Center for Children in Poverty. And in Nevada, the report they published, it's Early Childhood 2-Generation State Policy Profile. And in Nevada, 16% of our children underneath the age of 6 have 3+ risk factors. 16%. And 49% of our children have 1 to 2. So important to keep in mind how our children are being raised in our great state. So experiencing many ACEs that we discussed already, as well as things like racism and community violence without the caring, supportive adults around them, that exemplifies the toxic stress. And it leaves our bodies in this elevated stress response, and it creates wear and tear on our systems and on our health. And the reason why, and I love this analogy, it would be the same effect as revving your engine in your car for an entire week. Think of the strain and the stress that would have on an engine, giving that much fuel and adrenaline is going through that system. So that's what's happening when we talk about toxic stress. And I did get these copyrighted, by the way, these images. So there's, like I said, it's not a death sentence if children experience toxic stress. For those that have experienced multiple ACEs, there's a wide range of responses that can help, including therapy, mediation, physical exercise, spending time in nature, and others. But the best way to prevent is to making sure that our families with young children have access to the services that they need, and the system supports their holistic development. And one of the programs that the Children's Cabinet is involved with, we have been for years, is improving our early childhood comprehensive system. The Children's Cabinet wrote a competitive grant for a Health Resources Services Agency to address this comprehensive system that our children and families need for optimal development. And I'm going to turn it over to my colleague Denise Tanata, because through building a stronger system for our children and families, we can address toxic stress. We can ensure that 16% of our children don't experience 3+ factors that can lead to 3+ ACEs that can lead to toxic stress. So there's my overview on early childhood development, and I'll turn it over to my colleague Denise, and I will advance the slides for her here in Carson City.
Thank you so much. Do we have Ms. Tanata?
Yes. Good afternoon. My name is Denise Tanata. I am the Early Childhood Comprehensive Systems Director at the Children's Cabinet. As Marty mentioned, we last year the U.S. Health Resources and Service Administration, HRSA, through their Maternal and Child Health Program, released the Early Childhood Comprehensive Systems Health Integration Grant Opportunity. And in collaboration with numerous state agencies and private partners, the Children's Cabinet submitted an application, and we were one of 20 states that were awarded this grant. As the slide indicates, this is a 5-year grant beginning in August of 2021 for approximately $255,000 per year that focuses on strengthening early childhood systems. Next slide. The purpose of the HRSA Early Childhood Comprehensive Systems Health Integration Grant is to build integrated maternal and early childhood systems of care that are equitable, sustainable, comprehensive, and inclusive of the health system, and that promote early developmental health and family well-being, and increase family-centered access to care and engagement of the prenatal to 3-year-old population. And this initiative places a very strong emphasis on equity, particularly around ensuring that family leadership and engagement are there for decision-making throughout the system. Next slide.
Excuse me, ma'am. This is Kim with Broadcast and Production Services. We're just now seeing your screen share once again. Thank you.
Thank you for letting us know. Please go ahead.
Thank you. Again, for the record, Denise Tanata. The next slide shows the partner agencies and organizations. Those who are listed here are those who provided a letter of support for our grant and participated in the development of the grant. You can see multiple state agencies as well as private partners throughout the state of Nevada. We continue, as we've begun implementation of this initiative, have continued to grow our list of partners. The project is looking at not only how we can better align and coordinate state agencies and departments within the early childhood system, but also how we can align, coordinate, and integrate initiatives and related work that's happening in the private sector. Strong public-private partnerships are essential to building a comprehensive, coordinated system that delivers equitable access to high-quality programs and services that meet the needs of all families in Nevada. Next, I'll go over the goals and objectives of the grant. So the HRSA ECCS Health Integration Initiative includes Yes.
I apologize for the interruption again. This is Kim with Broadcast. There you go. We keep losing your screen share, but I see that it's back up again. Thank you. I apologize for the interruption.
Okay. Again, for the record, this is Denise Tanata. So we have 5 overarching goals. Goal number 1 is to increase state-level infrastructure and capacity in Nevada to strengthen statewide maternal and early childhood systems of care. Our objectives under this goal, 1 is to create the Early Childhood Comprehensive Systems Director position, which is the position I currently hold. Also establishing the position of an Early Childhood Comprehensive Systems Parent Engagement Coordinator. So we've hired Miss Ashley Dines, who's doing that work statewide, and that's a position that is actually co-funded through the HRSA grant, and then also through the Division of Welfare and Supportive Services with the ARP funds. So that's one of the collaborative initiatives that we have. to do the parent engagement. We're also, long-term goal is to establish a governor's office for early childhood in the state of Nevada. There are numerous states that have already established similar offices to address the complex system of early childhood, to align policies, procedures, and resources to better address the holistic needs of young children and their families. We're currently in the process of developing a concept document, researching how other states have aligned those offices and the coordinating cabinets to outline a potential structure for us here in Nevada, and particularly aligning that with our existing Early Childhood Advisory Council. Next slide. Goal number 2 is increasing coordination and alignment between maternal and child health and other statewide systems that impact young children and families to advance a common vision for early developmental health and family well-being in Nevada. We're currently working on a comprehensive system asset and gap analysis in collaboration with our Hersa technical assistance partners. The system asset and gap analysis will be complete later this year, and we'd be happy to share that with you once it's done. We're also contracting with a national organization, the Children's Funding Project, to conduct a fiscal mapping analysis that will result in a dashboard that we can update on a regular basis. It will also include identification of our existing funding structures, opportunities for fiscal efficiency in the early childhood system, as well as gaps in resources and opportunities to fill those gaps. Additionally, we are coordinating the development of a unified prenatal to 3 strategic plan in alignment with our Nevada Early Childhood Advisory Council. Next slide. Goal 3 is to increase the capacity of health and early childhood systems in Nevada to deliver and effectively connect families to a continuum of services that promote early developmental health and family well-being beginning prenatally. Here, one of our main projects, as was mentioned by Ms. Loper in the previous presentation, is we have developed the Early Childhood Community Health Worker Program, which actually started last month. We currently have 5 trained early childhood community health workers here in Southern Nevada. We're in the process of hiring for a coordinator in Northern Nevada and hope to have those community health workers out in the field this summer, with plans to expand those community health workers into the rural areas next fiscal year. I do want to note that this program, as far as we can tell, is the first of its kind and has the opportunity to serve as a model for other states, and we're already beginning to receive inquiries through our national partnerships for how we're developing this program and how it's working and benefiting our families. Next slide. Goal number 4 is to identify and implement policy and financing strategies that support the funding and sustainability of multi-generational preventive services and systems for the prenatal to 3 population in Nevada. As I previously mentioned, we're in the process of conducting a fiscal analysis. In that process, we're also looking at policy priorities. What is it that we need to do to change policies, practice, alignment between different state agencies, systems, as well as private partners to streamline access to programs and services that meet the needs of children and families. We're also incorporating these strategies into that unified prenatal to 3 strategic plan, which will ultimately be a part of our state Nevada Early Childhood Advisory Council strategic plan. The last goal is to increase state-level capacity to advance equitable and improve access to services for underserved prenatal to 3 populations. With this, we are doing health equity data analysis. We are looking at how we can enhance both collection and utilization of cross-sector data. Particularly looking at how we can make sure that we have disaggregated data, looking at race, ethnicity, geography across those systems. We have integrated a lot of these goals and objectives into our Early Childhood Advisory Council and have established subcommittees that align with each of these 5 goals. I also wanted to mention that under the equity piece, we've talked a lot about the emphasis on parent leadership and engagement in decision-making process. We are in the process of establishing a family leadership council where those families members will receive training, coaching, and resources to support their engagement on a variety of boards, commissions, task force, really starting with the integration of family leaders in decision-making roles, beginning with the Nevada Early Childhood Advisory Council. Also, we will be providing training and technical assistance, beginning with the Nevada Early Childhood Advisory Council, on strategies, policies, and procedures to support and encourage parent leadership opportunities. We've recently restructured our state Nevada Early Childhood Advisory Council to align with these goals and objectives, including those 5 subcommittees. Our goal is to align and coordinate systems as well as policy to better serve children and families, ultimately resulting in improved outcomes and reducing the need for more costly interventions past the early childhood years. So thank you. That concludes my presentation. I believe we're open to answer any questions that you may have.
Thank you so much for the presentations today. Are there questions from the committee? I see Dr. Hardy has a question. Dr. Titus also has a question. We'll go ahead and start with you, Dr. Hardy. Please go ahead.
Thank you, Madam Chair. One of the things that intrigued me, which Director Elquist said, is it changes the DNA. I hope she meant the effective DNA, because I don't think we change our DNA. Am I mistaken there?
Dr. Hardy, thank you for the question. Marty Elquist for the record. I am not a medical doctor, so I do not know the difference between effective DNA. I just know the research as I read it, and I can get back to you. Harvard Center for the Developing Child is largely the source that I go to on anything regarding toxic stress and brain development, as well as University of Washington Center for Brain Sciences. Those 2 sources are the go-to sources. Harvard Center for the Developing Child more so on the research behind toxic stress.
I appreciate it. I just wait for a DNA sample of 21-year-old person that we had a DNA sample when they're 6 months old, and it's not the same person. And I'm curious if Harvard has enough doctors that have figured that out. Thank you.
Thank you for the question. We'll go ahead with Dr. Titus and her question.
Thank you, Madam Chair. And thank you, Dr. Hardy, because I too was going to ask the question about what changes our DNA. And I was just curious about what resource you had for that. And if you could forward any document that you saw that would change our that DNA was actually changed by behavior modification or intervention. I'd be very curious to see where that documentation is. The second, just more of a question or an observation, is I'm an old doc, went to medical school a long time ago. Undergrad, I did a lot of child psychology and all, and I would just observe that we certainly have come a long way from the 1940s and B.F. Skinner and the Skinner box on how we treat early childhood development. So thank you for your presentation.
So true, Dr. Titus. I was actually admiring your presentation and the discussion about our neurons and synapses. It is essentially the presentation I give my children when they say they don't want to go to school or eat healthy foods, or they want to give up on the thing that they think is hard, because that is how we learn, is building those synapses. So yeah, we're on the same page. Are there any other questions from the committee? I cannot see the committee in Las Vegas, so Assemblywoman Gorlow and Assemblyman Hafen, if you have questions, please unmute yourself. Otherwise, I think we we'll move on to the next portion of this presentation, and that will be on health outcomes for children and policy considerations. Thank you so much again for your presentation today. We have Dr. Tyler Gardner, I believe, and some of her fellow colleagues with the Children Advocacy Alliance to talk about this particular issue. Please go ahead and introduce yourself and begin when you're ready.
Good afternoon, and thank you, Chair Peters and committee. I'm Annette Dawson-Owens with the Children's Advocacy Alliance. We appreciate the opportunity to come and share with you today. Over the course of this interim session, you have no doubt heard a number of startling statistics and outcomes for children and families here in Nevada. As we think about all that has been shared or will be shared, I'm reminded of a quote by Marian Wright Edelman that states, "The question is not whether we can afford to invest in every child, it is whether we can afford not to." We want to underscore that we do not have time to not invest in our children. And so with that said, I want to give you an overview about what you will hear today, particularly about the state of our children. Dr. Tyler Gardner will not be with us today as she had a board commitment that she needed to attend to. But you will hear from myself, the Policy Director in Early Learning, Annette Dawson-Owens, and I will talk about a number of reports that we routinely develop and share as resources for you and others to make sound decisions about the things that will improve outcomes for children and families. We will also hear from our Strong Start Prenatal to 3 Initiatives Director, Jamel Nance, who will share about a collective effort underway to transform conditions for children, particularly leveraging a number of investments that you have even recently perhaps supported, whether it be home visiting, infant and early childhood mental health, leveraging community health workers, improving maternal outcomes. There is something that can be done to change the trajectory for our children, and we implore you to do so. The Children's Advocacy Alliance is a 23-year statewide, independent, nonpartisan policy organization advocating to improve outcomes for our children and families in Nevada in 4 key areas: education, health, safety, and economic well-being. In keeping with this commitment, each year we publish a number of reports to aid others in conceptualizing and addressing the state of our children and families in Nevada. Today, this presentation will have a message that will highlight key findings related to health and other areas leveraging those resources. Next slide, please. You will hear about a number of reports, including our Kids Count 2021 data book, which will have another release in August of this year. You will hear a recent pandemic report, a special report talking about the latent effects of the pandemic, and highlight a few pain points for children and families during COVID. We will also share our routine but insightful children's report card. The main takeaway is that we are in this together, so we would love to partner with each of you in not only sharing these key resources, but also supporting your efforts to craft sound policy decisions for children. As part of that commitment, you will not only hear those startling data points, but also a path forward, particularly as it relates to early investments and the Prenatal to 3 policy roadmap, which is an opportunity for you to change the trajectory through policy. Next, please. As we stated, we will talk about the Kids Count Data Book of 2021, our Nevada Children's Mental Health Report Card, our Pandemic Report, and our Children's Report Card. All of these resources can be found on our website in their entirety. We anticipate all the data in our reports, however, may actually be worse post-COVID. So we start by highlighting the Kids Count Book 2021, noting that a new data book, again, will be released in August, but where Nevada is currently ranked 45th overall. We are 41st in economic well-being, 46th in education, 44th in family and community. And next slide, please. A little more positive, you can see here we are ranked 34th in health. However, we failed or got worse in low birth weight and children and teens who are overweight or obese. We did make gains with regard to children without mental health insurance, as well as children and teen deaths. Nevadans' overall grade in children's mental health was a D+. Next slide, please. Nevada could benefit from the state investing in a comprehensive data management system so that we can have real-time information to understand the needs of children and families and act accordingly. Pain points seen through COVID-19 relate to, next slide, please. Only 13% of our families and children having access to help with insurance costs. Next slide. Nevada has a 17% lack of consistent access to food or food insecurity, while the national average was 14%. Next slide, please. This slide shows that Nevada was ahead of the national average with 26% of individuals feeling the effects of depression compared to the national average of 21%. Next slide, please. This slide shows the national effect of racial disparities across such areas as not having enough food, not being able to pay your mortgage on time, not having health insurance, and feeling depressed or hopeless. Again, we need to pay attention to the disparities that exist between different groups related to race. We will now highlight the Children's Report Card from 2020. The next slide highlights safety, where we earned a C+. Thank you. Education, where we earned an F. Economic well-being, where we earned a D+. And the one we'll delve deeper in today, health, where we earned a D. Our health outcomes, you see that access to health care was rated as an F and stayed the same as in previous years at the bottom. Prenatal and infant health went down and was rated as a D. Immunizations went up to a C-. Childhood obesity was a C- as this grade dropped. Dental health was an F- and decreased. Mental health was a C and decreased. Sexual health increased to a C. Next slide, please. In the state of Nevada, the rate of uninsured children was 8% versus 6% in the United States, and we're rated 45th in the country. Next slide. However, due to COVID-19, numbers have doubled, and 8 million Americans lost employer-sponsored health insurance, with persons of color being disproportionately impacted. Again, we are in this together. Some of the data is startling, but there is a path forward that you will hear about relating to early investments, as well as the prenatal to 3 policy roadmap, an opportunity to change the trajectory for our Nevada children through policy. I will now turn the time over to my colleague, Jamel Nance, who is the Strong Start Prenatal to 3 initiative speaker.
Thank you, Annette. And thank you all for all the presenters that have given such great information today. Hopefully this will kind of bring it all around full circle. So here in Nevada, I'm sure you've heard the term Strong Start in many different entities. Strong Start was coined as a campaign for community outreach that's aimed at mobilizing parents, educators, advocates, community, and business leaders to make quality early childhood experiences a priority in the state. Children's Advocacy Alliance is the backbone organization that supports the Strong Start Coalition. The Prenatal to 3 initiative is an initiative that is supported by the Pritzker Children's Foundation. So that is something that we have worked diligently together with a plethora of community partners and business leaders to really move this initiative forward. The coalition is broken down by the implementation of 3 work groups to support the policy and resources that produce the best outcomes for young children and families. So those 3 work groups include the Strong Start Prenatal to 3 Maternal and Child Health Work Group, the Community Health Workers and Home Visiting Work Group, as well as the Early Learning Child Care Work Group, and some of which are on this call today. So we are excited to be able to speak to this initiative. Some of our goals in the Strong Start Coalition include having an additional 2,215 infants and toddlers that fall below 200% federal poverty level to utilize well child services under the 12-month continuous eligibility of Medicaid. So this is something that has come up as a reoccurring initiative that we want to support, is that 12-month continuous eligibility of Medicaid. We also hope to add an additional 8,500 pregnant people below the 200% federal poverty level on Medicaid that receive and utilize postpartum care services through Medicaid expansion. So again, looking at the 12-month continuous eligibility for those parents. And then in addition, we hope to add at least 450 infants and toddlers below the federal poverty level of 200%, having more access to quality childcare through the establishment of 450 contracted childcare subsidy slots of 3, 4, and 5-star centers, meaning that they are of high quality childcare providers. So again, we talked about how childcare is giving us that holistic approach to health of not just the child, but of the family, to buffer some of those disparities that we see in those adverse early childhood experiences. Okay, so if you have the luxury of participating in our Winter Policy Summit, we have the opportunity to have Dr. Osborne present on the Prenatal to 3 Policy Impact roadmap that we have been heavily utilizing as a research-based model to discuss some of those policy goals that have the best outcomes for our children and families. And so I won't go through all 8, but we have highlighted 3 of those policy goals that we would like to continue to hone in on as we move forward. So 3 of the outcomes that we have really pulled out as things that we are truly highlighting here today is access. Again, families having access to necessary services like we talked about today through community health work, through healthcare services. Also reduced administrative burden. I know that there have been some movement with the Medicaid eligibility requirements to recertify. Identification of needs and connection to services, again, through our community health workers and home visitors. Parents' ability to work. I know we talked about this a lot during the pandemic when we were heavily into it about families needing to return back to work. But that also entails our childcare providers being sustainable and being able to have the resources that they need to continue to keep the doors of our childcare providers open, and parents being able to find sustainable work as they have family-friendly work environments that allow them to take that 6-month leave when children are born. So again, another opportunity for children to bond with their parents through that 6-week paid leave. That's something we are definitely interested in, and just being able to support our families, not both in the work environment, but also in the opportunity to return to work with that connection to childcare. And again, having equitable health and birth opportunities, so connecting families to services like we talked about today that produce the best outcomes for health. And again, just to highlight a few points for the policy roadmap, again, looking at where we rank in relation to other states. And although this data is not favorable, I think it's important that we highlight that there are specific areas here that we have moved forward in. However, we still have a ways to go. Looking at the percentage of low-income women that are uninsured, falling at the 27.6%. And ranking 40 amongst other states. Also looking at eligible families with children under 18 not receiving SNAP. So again, we look at those ones who are maybe eligible but not yet receiving services. And so our big mission is to really increase that utilization of services that we know is so important to our children and families. All right, so policy opportunities. We work really hard with our partners to determine what policies really impact children and families, and not just research-based, but really honing in on those community-based organizations, our state partners, to really refine our policy priorities. And so at this point, we are really highlighting equity in all policies. We talked about equity numerous times today, but we want to really highlight the importance of equity in all policies, that all families have access to vital services and resources, including home visiting, infant and early childhood mental health services as such. And then as well as parents' ability to work, including ensuring a sustainable childcare workforce with livable wages. And lastly, ensuring healthcare access for children and families, including 12-month continuous eligibility coverage for children as well as pregnant people. All right, any questions?
Thank you so much for the presentation today. Are there any questions from the committee on these presentations or this presentation? I am not seeing any. Thank you so much for the information and for being here today. We really appreciate you and your time. And thank you again for your slides on the kind of your policy summary. We appreciate that, and we'll be looking at those issues. All right, we're going to go ahead and close this agenda item and move on to our next agenda item, item 14, early intervention services for children birth to 3 years of age from the perception of a provider. We have invited Foundation for Positively Kids to present today on this topic. We also have Robb Burns, who is the president of the Early Intervention Community Provider Association, available for questions after the presentation. Do we have folks? I can't tell if they're in the Grant Sawyer building or online, but please go ahead and introduce yourself and proceed when you're ready.
Good afternoon, Madam Chair and members of the committee. My name is Paula Hammock. I'm the Chief Strategy Officer for the Foundation for Positively Kids. My colleagues at the table with me today are Jennifer Lagana, Vice President for Early Intervention Services for Foundation for Positively Kids, and Robb Burns, President of the Early Intervention Community Provider Association. We do have a PowerPoint. I'm going to try to get it up. It looks like I need to have a password to get in, so maybe I can get some technical assistance.
Do we have IT in Grant Sawyer who can come and assist? Oh, perfect. It looks like someone's down there. Thank you so much.
Great, thank you. Again, for the record, Paula Hammock, Chief Strategy Officer for the Foundation for Positively Kids. See, there we go. So we'll just give you a brief overview of the Foundation for Positively Kids. We are a local nonprofit located in Clark County. We were established in December of 1999 by our Chief Executive Officer, Fred Schultz. We provide several services to children to include early intervention services for children that are 0 to 3 years of age. We also provide 2 pediatric clinics here in Clark County. One actually is on the Child Haven campus.
I'm sorry, I don't mean to interrupt, but we are not seeing your presentation in Carson City. I don't know if that is a broad.
Thank you, Chair. This is Kim from Broadcast. We are working on that. One moment, please.
Perfect. We can see it now.
Thank you. Again, for the record, Paula Hammock with Foundation for Positively Kids. We also provide 2 pediatric clinics, as I said earlier. We also provide behavioral health services for youth 0 to 17 years of age. We also provide a social skills program for children 0 to 5 that may or are on the autism spectrum. We are currently working on becoming credentialed as an ABA program through Nevada Medicaid. And we also are in the process of becoming accredited as a home health program with ACHC. Some statistical information, and I won't go through all of it because it's pretty easy to read, I believe. But we have been a community provider of early intervention since 2009. We are currently servicing, as the writing of this PowerPoint, we were at 220. Today, we are at 225 children with 60 awaiting evaluation. Based on the children we serve, the most common service they need is speech. You can see that we average about 250 visits a month for speech therapy. PK Positively Kids has 3 full-time speech therapists and 1 part-time speech therapist. We also have 1 full-time occupational therapist and 1 part-time physical therapist. And then we have developmental specialists, and they provide on average about 300 visits a month for special instruction. I always like to start with the challenges and then we can end on a positive note. I think that's always best. But some of the challenges that we have in early intervention, which I'm sure is not new information to you all, is that the current computer system that is utilized by EI is outdated and not user-friendly. It is a case management system that does not incorporate billing processes, thus requires the same information to be entered into two different systems, making for duplicative work. Additionally, it doesn't have the capability to run reports that would assist in helping providers to track performance and outcomes. Since the pandemic, it has become increasingly difficult and to hire qualified staff that are willing to return to a home-based setting, which is not just something that PK is experiencing. I think that's overall. This is a larger issue as we are now being forced to compete with other corporate employers who are seeking similar qualified applicants and have the financial means to offer bonuses or have higher hourly rates. And that's, for example, like our speech pathologists. They are in high demand, as well as our occupational therapists and physical therapists. This also creates an issue with staff retention since employees are often seeking higher hourly rates. Specific to the bullet point that states return of referrals generated from PK clinic, I wanted to be clear as what we mean by that is that since Positively Kids has 2 pediatric clinics, sometimes children seen there are referred for EI services. That referral is sent to the state for assignment, and there's no clear mechanism to ensure continuity of care for PK, as we may not be the provider assigned to the family for early intervention services, possibly due to parent choice, of course, or because the case is randomly assigned to another early intervention community provider. We have very limited audiology services here in the state of Nevada, specifically to the county. The services for audiology is limited to only one provider and at one location. As stated earlier, early intervention services are provided to children between 0 to 3 years of age, and once they are 3, they are transitioned over to providers that service the age range of 3 to 5. Clark County School District is primarily the primary one that services those youth. We've heard that a lot of times children fall through the cracks, though that is anecdotal information. We don't have any way to track it because we're not the service provider. Something maybe to consider in the future is if EI was extended to 5 years, we may be able to meet, if EI was extended to 5, children's needs may be met or met before becoming school age. Again, you heard presentation about brain development, and those 0 to 5 years are critical. And so for kids to be dropped off at the age of 3 to another transition that may or may not be able to service them, it would behoove us to consider maybe moving to a 0 to 5 for early intervention services. Some of the successes. Because we offer several types of services at Positively Kids, we are able to provide a continuum of care for a number of children we serve, especially those that are medically fragile or developmentally challenged. We have developed our own internal EI audit process, thanks to Ms. Lagana, and we are also an active member of what we call Positively Kids Quality Assurance Program Improvement Committee, which we are always looking to improve our processes. During the pandemic, one of the positives that did come out of that was that as we were providing telehealth services, it assisted our staff in strengthening their parenting coaching skills because it was having to be done through telehealth, and so we were not necessarily in the home, so really coaching up our parents to provide the service. PK continues to maintain a strong relationship with the state EI representatives, and we are committed to collaborating with the state and community partners to ensure that the children we serve are getting the best care possible. We are hopeful that over the next few years we will be able to expand services we can provide to the children we serve. going forward, hopefully in the rounds of maybe, we're hoping to launch a pediatric skilled nursing facility, and we are considering looking into providing medical daycare for these kids that are medically fragile. That concludes my presentation, and so we are eager to take questions if warranted. Thank you.
Thank you so much, and I appreciate you bringing your challenges and then ending on a success note. We always like to celebrate our successes in this state, but our job at the legislature is really to take on those challenges and find solutions and help enable our partners both at the state and in our private sector on ensuring that we're providing services where they need to be provided. So I appreciate, again, your challenges slide, especially so we can start to work on some of those solutions. Are there any questions from the committee on this one? I believe Miss Gorlow, Assemblywoman Gorlow, has a question. Please go ahead.
Thank you, Madam Chair. And just for transparency, I actually work at Positively Kids. However, I do not work directly with the early intervention program. But I wanted to talk a little bit about the children that are being seen, what kind of delays that you're seeing, and also the children that are awaiting evaluation. So could you explain a little bit more about how a child qualifies for early intervention, and then the wait list that's currently, that we're all experiencing? Thank you.
Thank you, Assemblywoman Gorlow. Jennifer Lagana for the record. Currently, children qualify for early intervention services under 4 different categories. They would have to exhibit a 50% delay in one area of development, a 25% in two or more areas of development. They would have to come in with a diagnosed medical condition, which falls under the category of auto-eligible, or we also have the category of informed clinical opinion. So there are times when children don't necessarily meet the other 3 criteria, but the team really feels like this child would benefit from the services, or that the family really would benefit from our support. Most of the children that we see come in with developmental delays, and that can be in any of the 5 areas of development. We assess cognitive, adaptive, self-help, communication, and physical domains. We get our referrals primarily from pediatricians' offices, but we do occasionally get calls directly from parents who have noticed that maybe their children aren't doing the same things that other children their age are doing. The referral process is that all the referrals go through the single point of contact, which is NEIS. And parents do have the right to choose which program they want, but if a parent does not have a preference, then they are assigned to the next available program in the rotation.
Thank you very much.
Thank you, Assemblywoman. I just wanted to ask Mr. Burns, did you have anything you'd like to add from the perspective of the Provider Association on this topic area?
Thank you, Madam Chair and members of the subcommittee. It's a pleasure to be here with you guys today, and it's good to be back in public view out of the House and seeing each other do what we can to kind of make this situation better for the children and their families. I'd simply echo the presentation slide, I believe number 4, in terms of the trade associations. The trade association represents all the community providers with the exception of one, both in the North and the South here in the state of Nevada. And I think that there are 2 critical points here brought out in this slide in particular that we could certainly benefit from the state's help. And it's the critical staff shortages in terms of staff hiring and retention is going to be a huge one. As my colleagues presented earlier, there are other entities in the healthcare system that can offer reimbursement rates or payment rates or salaries that in the early intervention program we just aren't able to do. And then I think that the staff retention on our side and our programs are then compromised. And then lastly, I'd add then that we have to make sure that we are adequately funded so that we can continue to service the children, because after COVID, it's our opinion that our child find efforts will increase and we'll see more of a need and a greater need as we move forward in post-COVID years. So I appreciate the opportunity to address this body, and thank you.
Thank you so much. Thank you for being here today. Appreciate the perspective. Are there any other questions from the committee, from the provider perspective presentation? Well, thank you all for being here. We really appreciate your presentation and time in our committee. And we will go ahead and close that agenda item and move on to our next agenda item, item 15. This is the Early Intervention Services System in Nevada, assisting in the children's development between birth and 3 years of age. We have some folks up here in northern Nevada. Do you have colleagues in Las Vegas who are also? Go ahead.
Ricky Robb for the record. We have them remotely, and there's actually 5 of us, so that's why we're here. And Nikki is here to support us in our presentation today.
All right, I see some folks popping up on the Zoom. I'm going to go ahead and let you take the lead on who's presenting, and go ahead and introduce yourselves and begin when you're ready.
Great, thank you. Good afternoon, Madam Chair and members of the committee. For the record, my name is Ricky Robb. I'm the Deputy Administrator for Children's Services with Aging and Disability Services. And to start our presentation today will be Fatima Taylor, who is our Program Manager in our southern region. So I'm going to turn it over to Fatima.
Good afternoon, and thank you for the opportunity to present today. For our PowerPoint presentation today, we will take you through our overview of early intervention services. So this is a collaborative effort between Aging and Disability Services Division.
Fatima, my apologies for interrupting you. We need to wait for the presentation to pop up on the screen.
Okay.
Are we good?
I'm sorry about that.
Okay.
We have it in northern Nevada. Can you see it in Grant Sawyer and online?
We do not see it down here.
All right. Will you let us know when it pops up for you?
We now have a very small view of it, Chair. I'll follow along on my computer.
Okay, thank you. Yes, we have these resources both available online, and there should be printed copies that you can grab in the room there with you. Please proceed when you are ready.
Okay, good afternoon. We will start over. I'm sorry that it's going to be so small, but if you can follow along, that is awesome. My name again, Fatima Taylor, Clinical Program Manager with Nevada Early Intervention Services. This presentation today is a collaboration with the IDA Part C Office and Aging and Disability Services Early Intervention Services. And presenting with me today is Dr. Lorianne Molina, the IDA Part C Coordinator, Sarah Horseman-Ploger, Health Program Manager with Nevada Early Intervention Services, and Ricky Robb, Deputy Administrator, Aging and Disability Services Division. For our agenda today, the presentation will include a general overview of the early intervention system, successes and challenges in meeting child health outcomes, and critical employee shortages. For the next slide, we'll start with the overview of the early intervention system. Early intervention is an array of services and supports for infants and toddlers, from birth to 3 with disabilities or developmental delays. These services help their development and help them reach their full potential. When we look at these services, they're at no cost to families. Our funding sources are state general funds, IDA Part C funding, and insurance when families give us permission to bill. For our next slide, we'll talk about why early intervention is important. Early intervention is important because it has a lasting impact on the child's overall development, how they learn, and how they're able to regulate their emotions. We've already heard in previous presentations about the critical time of the first 3 years of life for brain development, and early intervention can really, when presented timely, can improve the quality of life for children. I will go ahead and pass it over to Dr. Lorianne Molina, and she will present the next set of slides. Thank you.
Dr. Lorianne Molina Level here for the record. I'm the Clinical Program Planner 1 and Part C Coordinator for the Individuals with Disabilities Education Act, IDEA, Part C office. As Fatima had presented, our target population is from birth to 3 years with delays or disabilities. And here for you is further representativeness within our population. During December 2021, our federally required point-in-time count was 3,136 children. Of this population, a majority or 65% are male, with 35% female. Our system does not yet have sexual orientation, gender identity, SOGI data, but we are planning to develop processes to provide this required data within our new data system, which is expected to be implemented during 2023. Further representativeness by race, ethnicity during 2021 is reflected here for you below for your reference. Our early intervention system is endeavoring to increase representativeness through a number of child-find community outreach efforts and through advising from our Early Intervention Equity Subcommittee. And next slide, please. Stakeholders within our early intervention system include the following entities we wanted to share with you today. We have the governor-appointed Interagency Coordinating Council, ICC, which is a federally required advisory board for all states participating in IDEA Part C. The ICC is comprised of stakeholders across the field of early intervention, with subcommittees for child find, family participation, and for equity. Next, we have the IDEA Part C office, which is the lead agency providing general supervision and regulatory oversight of the comprehensive early intervention services system in Nevada. We receive formula grant funding and federal oversight from the United States Department of Education, Office of Special Education Programs, OSEP. We have offices in Carson City and Las Vegas. And we're pleased to collaborate statewide with the Aging and Disability Services Division, which provides the day-to-day operations of early intervention services throughout Nevada. ADSD oversees and manages service delivery and service agreements. They are the system point of entry, SPO, for all referrals to the system. They also manage phase planning for services during the COVID-19 pandemic, and they manage the early intervention system budget made up of general funds, insurance billing, and IDEA funds. At this time, our presentation will continue with my esteemed colleague, Sarah Horstman-Ploger.
Thank you, Lorianne. This is Sarah Horstman-Ploger, Health Program Manager 3 of Nevada Early Intervention Services, Aging and Disability Services Division. As Fatima had mentioned before in slide 3, we have an array of early intervention services that we provide in the state, and some are listed for you here in this slide. And we do like to point out that services for children who are eligible are at no cost to families and are provided in a child's natural environment. Down below, as Lorianne had mentioned, we have direct contact information for anyone to refer a child through our system's point of entry at those phone numbers listed below. Next slide, please. And as we've had our colleagues at Positively Kids present before us, we have outlined here for you the state regional offices, as well as our community partners and the regions that they serve. We want to let the committee know today that each program serves IDEA Part C required services. Additionally, the state regional offices exclusively serve children or the most medically fragile infants and toddlers, as well as some non-Part C related programs and services, such as our captive program, which was mentioned at a previous presentation, Child Abuse and Protection Treatment Act, as well as a screening and monitoring program that we have within the state that are for children who may have been released from the NICU without significant medical needs. Also potential fetal alcohol syndrome suspicions, in addition to also potential neonatal, gotta get my notes here, neonatal abstinence syndrome. So we have both of those services that the state holds, and at any time, if any of those children under our CAPTA or screening and monitoring program should show more significant concerns, a family has the right to refer to Part C for full assessment and eligibility determination. I will now turn it back over to Lorianne Molina-Lovell.
Dr. Lorianne Molina-Lovell, here for the record once again. We're proud to share highlights of successes occurring in our early intervention services system. During COVID-19, our system ensured the continuity of services to families with the use of alternative service methods, such as telehealth services, allowed under OSIP and Medicaid. During federal fiscal year 2020, our EI system met our state systemic improvement plans, SIPs, target for children exiting early intervention services who had made progress in their social emotional development, with the target set at 68%. And the actual achievement reflected that 74% of children exiting statewide had made progress in their social emotional development and outcomes. This importantly ties into mental health for infants and toddlers. We attribute this success to the thoughtful, hard work from many among our early intervention and quality assurance programs, personnel, practitioners, families, and stakeholders promoting social-emotional pyramid model efforts. Another highlight is regarding our American Rescue Plan funds, which are being allocated with consideration of data-driven needs and stakeholder input within our EI system, including a new data system, which was addressed by our colleagues from Positively Kids in their presentation immediately prior to this presentation. A system study to further identify system needs and solutions, and training and professional development for the retention and career growth of early intervention personnel. Next slide, please. Challenges experienced in our early intervention services system included that children under the age of 5 are not eligible for vaccination, and 50% of families surveyed during spring of 2021 responded that services via telehealth methods were challenging. And many families experienced challenges during the pertinent juncture of transition exit at age 3, which is the period of time when a child leaves our early intervention services system and when they may go on to receive services with their next program, such as an early childhood special education program or preschool. There towards the bottom of this slide is an excerpt of our Part C office's federal reporting to OSIP regarding families who found themselves waiting at the crossroads between early intervention and their next program, with delays and limitations that were attributable to the COVID-19 pandemic. Next slide, please. OSIP does provide guidance to states for when services are impacted due to COVID, such as procedural safeguards, and timely notifications to families. We will note that OSIP allows states to apply for additional flexibility to use IDEA Part C funds to serve children beyond age 3 under IDEA, specifically with an extended option. This option extends services to a child who previously received EI services until the beginning of the school year following the child's 3rd birthday, with parental consent and according to IDEA regulations. OSIP provides state incentive grants, SIG, to these states that elect to offer Part C services beyond age 3 under IDEA. At this time, early intervention is legislated for the birth to 3 years population. At this time in our presentation, we'll continue and conclude with ADSD Deputy Administrator Robb.
Thank you, Lorianne. Again, for the record, my name is Robb, Deputy Administrator for Aging and Disability Services, Children's Services. Based on the information shared by the community partners, the Nevada Early Intervention Community Partners Trade Association, known as the Trade Association going forward, and the state programs, it has been determined all early intervention programs are continuing to experience critical shortages in both direct and indirect staffing. As you've heard from our previous provider, it has definitely been an impact to early intervention services. The shortages directly impact Nevada's youngest and most vulnerable population and their families needing specialty services. The impact to Nevada's early intervention system is the risk to this vulnerable population waiting for critical and timely services, with the goal to not negatively impact a child's development due to these challenges. It also could result in a corrective action from OSEP. And it also could put us potentially with a wait list, which we have not seen in many years. So our goal is to find a way to eliminate this critical shortage and be able to serve our populations appropriately. Due to the critical shortages for developmental specialists, what we call a DS, there have been multiple requests to modify the current requirements of the Early Intervention Educational Endorsement. We are currently working with the IDEA Part C office in the review of the potential options for licensure and retentions to ensure the special population receives critical services, timely and by appropriately educated staff. The next slide, please. Slide 13. We're excited, so we will be ending on a really good note, which is something that we've been waiting for quite some time. The funds, the Arpa funds through OSEP actually afforded us to be able to work on 2 initiatives that we've been working towards for many years. A system analysis, which started with a analysis of our rate study. As you all remember from our last legislative session, we really did talk about rates and what did that look like for a comprehensive provider. The study has begun. We've got the initial data that was presented to the trade association as well as the comprehensive community providers last Friday. And so we're now in that phase of public comment. So they're working towards that public comment, and that will close June 3rd. And then the HMA study, I just totally forgot to introduce who's doing that. So the Burns and Associates are actually the group through Health Management Associates who's conducting that study as a third party. We've been able to work with them to provide the information for the state providers as well as the comprehensive community providers. So far, we do have an initial draft of that study. And again, that was presented last Friday, May 13th. And we look forward to that public comment period to ensure that we have all the information before that final analysis. The comments will be evaluated, and then we'll be able to have that finalized, and we hope to give that information to all of you in a future meeting. The analysis will also be reviewing the 50-50 requirement of the caseload split and the impact to services. It does impact service delivery when the system must enforce a rotation hold on parent choice Parent choice is what's required by OSEP and as that federal law. It's also the right thing to do when we are allowing a family to choose which provider they would go to. In the past, we have found that when we're not at that 50-50 caseload split, that we have to artificially stop that parent choice and take a program out of rotation, which is typically those community providers, which is not in supportive of that parent choice model. And so it's really important for us today to share with you that that's an impact to the service and to the child and to the family if they're not able to have their choice of the community provider or the state provider they'd like to have their child receive services. So ensuring that we're within compliance with OSEP, we would like you to hear that request as we move forward and when we go into the next legislative session. The great thing is we've learned many lessons already, and we're only at the beginning stages of the analysis. And through this, we've learned how different our state is, that Nevada is structured very differently from other states for early intervention services. One of those differences is how we are structured with the Part C IDEA office, Aging and Disability Services, our quality assurance, and the Nevada Early Intervention system as a whole. We're in different divisions. So there are times that that division actually separates us in the alignment of our funding, compliance, as well as our service delivery. So again, those are just items to keep in mind as we're moving forward with our analysis, as well as when we move into the next phase through the legislature. The second initiative is another exciting initiative that many of you already know about that we've been working on. I've been with the program for almost 5 years. We've been working on it since I came in. So with the OSEP Arpa funding, we were able to work through the RFP process with purchasing, and we are excited to say that we have secured a vendor, and we're working towards the June BOE for that approval. So we're here 5 years later, at least for me. It's probably been almost 10 for us, the need. You heard them talk about the challenges of an outdated system. Our hope is that we'll be able to stop some of the triplicates that we have. Some programs have to put things in 3-4 times. Most are 2 at this point. So our track system will be eliminated, and then we will have a new system that is going to ensure that we have a comprehensive case management, billing, data, and federal reporting system that will be imperative for all of our programs to be successful, and that will help us to ensure that we are working for those children and being able to have them in all their information in one place. So no matter what program they're at, they're going to get the same system, the same processes, and the same supports that they deserve. So I thank you, committee, for taking the time with us. I know you guys have been here all day, so we really appreciate your time today, and we're open to any questions that you may have.
Thank you so much. That is very exciting. I'm a huge fan of work smarter, not harder, and those single input systems make life so much easier on the back end for quality control, in addition to on the front end and putting in the data that needs to be utilized later. Are there questions for this presenter today? I believe Miss Gorlow has a couple of questions. Please go ahead.
Thank you very much, Madam Chair. First, I kind of want to share that early intervention means a lot to me, not only because I do, for transparency reasons, I work for Positively Kids, but my own son was referred to early intervention when he was about 2. And I'm really excited to hear that you guys don't have a wait list, because when he was referred, there was a wait list. And he actually aged out before he was able to get any services. And even today, as he's almost 16, I can still see some of his speech issues that sometimes I wonder, would they have been corrected if he had speech therapy early on? He's fine, but as a mom, you always kind of wonder those things. So that did make me think, when I was looking at the auto eligibility, I noticed that one of the criteria was a 27-week preterm. My son happened to be 36 weeks preterm. I had thought that at one point that was 32 weeks. So has that changed, or am I just remembering improperly? Because, like I said, it's been 16 years.
Ricky Robb, for the record, I'm actually going to pass this on to our program staff, and I'm going to pass this on to Fatima Taylor.
Thank you for the question, Fatima Taylor, for the record. For auto-eligible kids, about that long ago, and that's my memory, so excuse me if it's not that great, but for preemies, it was the 27 weekers, but for the 32 weeks, if there was still concerns and they didn't come out, they wouldn't have been auto-eligible. What we could have done, informed clinical opinion to make the child eligible if there were concerns.
Thank you. And if I could ask another quick question, Chair?
Please go ahead.
Please go ahead. Okay, thank you. Since we're speaking of age, I really liked your graphic about the race demographics for those that are being referred to early intervention. But I was curious about at what age are children being referred to early intervention? Because as we know, the earlier the better, but my son didn't get referred to until he was 2. So do we have any sort of an age breakout on when these children are being referred? Thank you.
Ricky Robb, for the record, thank you for that question. I would not say that we have that information with us today, but we'd be happy to get back to the committee.
Great, thank you very much, and that's all my questions.
Thank you for the questions, and thank you for the responses today and that follow-up. If you don't mind sending that to staff, we'll get it to everybody else. Great. I had one more question for you to kind of dive in a little deeper on the workforce issue. You mentioned a couple of things of wanting to explore retention and recruitment strategies, but do you have any ideas at this point or partners you're working with on establishing what those might be? We've got a lot of movement in the governor's office on addressing this particular issue across the healthcare spectrum, but I haven't heard from your particular providers about being kind of brought into those processes. So can you talk a little bit about what that looks like?
Thank you for the question. Ricky Robb, for the record. Well, we're at a multi-level at this point. Some of them are state providers or developmental specialists. So obviously we have master's levels, some doctorate levels, and then they are also required to have an educational endorsement, which is specific to Nevada Early Intervention Services. That is one piece that we are looking at because we get them and at about 2 years they're like, I can't make the 3-year cutoff. And so we are working with Lorianne and her team with Part C to determine what that looks like, if there's modifications for that. So we're in the process of that review for developmental specialists. The other challenge is that many of them are contracted, and those are our speech and language therapist, our occupational therapist, as well as our physical therapist. With that group, they're all specialty therapists. Unfortunately, the state, as well as our community providers, are not able to compete based on what they're able to make either within a school district or the hospitals. And so that obviously would be a funding opportunity for us in regards to what that might look like. So there's many things obviously that we could look at when it comes to, we have found that therapies are not within the state range. They don't have a class spec. And so we would really look at what those ranges would be and how we might be able to meet that on a salary. So right now that's our specific when it comes to therapies, and then when it comes to developmental specialists, one of the challenges is that we require an additional, if they don't meet the criteria when they come in, there's an additional up to 3 years for them to meet that requirement. And I would put it out to my colleagues to say if there's additional information that you guys would like to provide, please do so. Please raise your hand.
Please go ahead.
Ricky, this is Dr. Lorianne Monero for the record once more. Thank you, Ricky, for sharing about those strategies for retention and recruitment. I would like to add that the IDEA Part C office offers flexible licensing options for developmental specialists that must meet their 3-year professional requirements. We provide an alternative licensure, or what we call an alternative certification, which is an equivalent of the Department of Ed endorsement in early childhood developmentally delayed for ages birth through 7. And this alternative certification provides savings for developmental specialists on licensing fees. And although they are required to take the very same coursework as the Department of Ed requires, there is additional flexibility, especially if needed for extensions on that time frame when developmental specialists can show that they need extra time with and that they have performed good faith efforts to meet their requirements. Some other strategies that we're utilizing in our system to promote retention include providing professional development hours at no cost to providers, and providers may use those hours toward licensure renewals with the Department of Education or with our IDA Part C office. And then I'd like to also add that we're also incorporating as many strategies as we can to address what is very prevalent in this field of public service regarding burnout and compassion fatigue. And so throughout our state, we are promoting self-care for our personnel, as well as diversity, equity, and inclusion efforts to support all personnel. Thank you.
Thank you. I had one more question related to the demographics breakout. I just flipped to that page when Ms. Gorlow asked her question. And this number of, or the percentage of Black children who are recommended for intervention services, can you talk a little bit about why that number may be so low? It just seems like particularly low population-wise, but it especially related to our white and Black, our white and Hispanic populations. If you have anything in regard to that.
Ricky Robb for the record. Thank you for the question. I will go ahead and ask that Lorianne if she has any information in regards to the question.
Thank you, Chairman Peters, for that question. Lorianne Molina Level, again, for the record. Chairman Peters is referring to the slide that depicts that 38% of children eligible for services are white, 37% Hispanic, and that low percentage of 9% for Black children, as well as for those lower percentages that you would see for two or more races, Asian, Hawaiian Pacific Islander, Native American, and American Alaskan. And I do not have that data with me at this time, Chairman Peters, but we can endeavor to locate that for you. Some of the information that has been brought to us is that these ethnicities and races are historically underrepresented. And so we are federally required by OSIP to increase that representativeness for those minorities in early intervention. Some of the efforts that we are endeavoring to complete to increase this representativeness includes engaging with our communities in various events, such as, and I can ask my ADSD colleagues to elaborate further on this because they are actually the ones involved right there at the direct level with the community and with families. But we do have those child find outreach efforts that we report on that are conducted throughout state and fairs, through parent council meetings. And then, as I had mentioned, we are endeavoring to address this through our Interagency Coordinating Council, ICC, Equity Subcommittee.
Thank you so much for the response. I would also be interested if you have any demographic breakdowns of your providers as well with regard to race. One of the things that we've heard over and over again is the lack of representation of minority healthcare workers, particularly in the mental and behavioral health space. So I'd just be curious what those look like and how they compare to the representative demographics of those you serve. So thank you for that follow-up if you have it. Are there any other questions from the committee? I do not see any. thank you so much for being here in your presentation. We really appreciate your time today. And we look forward to seeing some of these ideas come to fruition in session. We're going to go ahead and move on to our next agenda item. This is our final presentation for the day. Agenda item 16 is an update on the coronavirus disease of 2019 health crisis interim study pursuant to Senate Bill 209 of the 2021 legislative session. Vice Chair Doniate will go ahead and give us a brief summary of his findings so far. Please proceed.
Thank you so much, Chair Peters, and good afternoon to my colleagues. For the record, I am Senator Fabian Doniate, representing Senate District 10, and today I'm presenting the second update on the COVID-19 health crisis interim study pursuant to Senate Bill 209, which was passed during the 2021 legislative session. Before we begin, of course, similar to last time, I would like to mention that there's a handout that is available on the committee's meeting page. And as stated before, Chair Peters appointed me to lead the SB 209 interim study efforts during the January 20th, 2022 HHS meeting. And as I summarized during our last meeting, I decided to hold various roundtable discussions with relevant stakeholders for each of the interim study requirements. And I will go ahead and try to provide as much updates to the committee meetings over the coming months. The last roundtable that we held was on April 25th, 2022. I invited several stakeholders to our second virtual roundtable discussion, and this one focused on the requirements related to the COVID-19 pandemic on businesses, their employees, the economy. Specifically, we looked at examining the benefits and challenges of implementing a task force between public and private representatives to support private businesses and the population areas of the state. And then we also tried to examine the economic impacts of the COVID-19 health crisis using an equitable perspective. As with the first roundtable, stakeholders received a survey with different questions, and we gave them the opportunity to give us policy proposals that we could look at for next session. A list of the stakeholders and who received the survey or who responded to it is provided in the handout, and most of it comprised of state, local associations, and nonprofit entities representing various business sectors and employees throughout Nevada. In terms of the policy recommendations, which is probably the most important part of this handout, on page 2 of the handout, there's a summary of the high-level discussion themes that has been provided, along with the strengths and challenges encountered throughout the pandemic. Some highlights for you. First, the greatest strength identified was the resilience of workers and the entities serving their communities. And second, the greatest challenge identified is the critical labor shortage, which participants said is being impacted by both inflation and the high cost of childcare, transportation to work, and housing. Additionally, policy recommendations were also summarized on page 2. One recommendation highlighted the need to update the state's process for moving federal funds directly to those in need. And I want to note that this was already brought up during the first roundtable discussion. And of course, while there were consistent themes identified during the roundtable discussion, we received many different policy recommendations from survey respondents. Therefore, we decided to go ahead and outline those specific recommendations provided in the addendum, which you can find on page 3 and 4 of the handout. Chair Peters, I look forward to sharing the final updates of the study. Our next meeting, or our next roundtable is going to be on the discussion of our public health workforce. And then the final roundtable is going to be discussing health equity and special populations. So again, for you, Chair Peters, and any of the committee members, this concludes my remarks, and I'm available to answer any questions that you may have.
Thank you so much, Vice Chair Doniate. Really appreciate your effort and work in this space. And I know from folks that have an interest in this area, we really appreciate the inclusion and discussions that are quite specific and pertinent to the issues at hand. So thank you so much for your effort. Are there any questions from the committee related to this update today? I'm not seeing any. Thank you so much again. This report is great. I'm going to bring it up with the one from, I think it was our last meeting, look at the two together, and look forward to your final report in the coming months. Okay, we'll go ahead and close that agenda item today and move on to our final agenda item, public comment. We will start public comment with those in the physical locations and then move to public comment from anyone who has called in. There is no one in the room up here in Carson City. no one coming in as I'm speaking, so we're going to go ahead and see if anybody in Las Vegas would like to come to the podium for public comment. I'm not seeing anybody coming up in Las Vegas either. Staff in our broadcast and production services, please add the first caller to our public comment in the meeting. We may need to give this a couple of minutes because I know there is a lag. So I will ask for BPS to update me on public comment line in about 1 minute. All right, BPS, is there anybody on the public comment line at this time?
Yes, Chair, we do have one caller. Please stand by.
Thank you so much.
Hi,
Caller,
good
you're
afternoon,
unmuted and
Chair
may begin.
Peters. Oh, sorry. Thank you. Good afternoon, Chair Peters, members of the committee. For the record, my name is Katie Ryan, and I am the System Director of Government Relations for Dignity Health St. Rose Dominican. Today, you have heard from some of my colleagues about the need for additional Medicaid reimbursement for community health workers and peers when it comes to items like substance abuse, mental health, and violence prevention. Myself, Dr. Deborah Cools from UMC and the UNLV School of Medicine, along with a national group, the Health Alliance for Violence Intervention, would love to present additional information to this committee around other states that have done this work and allowed for additional reimbursement for providers for violence prevention. Our providers, particularly in our emergency departments and trauma centers, see these violence victims. 2/3 of victims of gun violence are Medicaid patients, and roughly 1/3 of them will be injured again without intervention. Hospital-based violence intervention programs consistently decrease the risk of being re-injured, generally from that 1/3 down to about only 4 or 5%, while increasing access to needed services such as primary care and mental health. Intimate partner violence is also a huge issue. 1 in 4 women have dealt with this issue, and consequences can range from physical injuries, chronic health conditions, mental health disorders, and even death. 1 in 5 homicide victims are killed by an intimate partner. We have been in discussion with Medicaid and others at DHHS, and there is an appetite to move forward, but we would also love the opportunity to present to this committee and also get your support and funding for this health equity issue. Thank you, and I'm available for any questions you may have.
Thank you so much. Together, I will, because of travel, I will be attending in Las Vegas at Grant Sawyer, barring any public health crisis circumstances and lack of travel. But at this point, I will assume to be down there. So I hope to see my colleagues in the building if you're able to make it. And with that, our meeting is adjourned.